Rationale of endodontic treatment. When the only tool you own is a hammer, every problem begins to resemble a nail. Abraham Maslow. 3. Injury to the calcified structure of teeth and to the supporting tissues by noxious stimuli may cause changes in the pulp and the peri-radicular tissues. Noxious stimuli can be physical, chemical, or bacterial. They can produce changes that are either reversible or irreversible, depending on duration, intensity, and pathogenicity of the stimulus and the host's ability to resist the stimulus and to repair tissue damage. On the basis of these premises, we can generalize that mild to moderate noxious stimuli to the pulp may produce sclerosis of the dentinal tubules, formation of reparative dentin, or reversible inflammation. Irreversible inflammatory changes caused by severe injury can lead to necrosis of the pulp and subsequent pathologic changes in the peri-radicular tissues. As the pulp is encased in hard tissues with limited portals of entry, it is an organ of terminal and limited circulation with no efficient collateral circulation and with limited space to expand during the inflammatory reaction. A clear concept of the fundamentals of inflammation is necessary for the understanding of the diseases of the pulp and their extension to the peri-radicular tissues. Inflammation. Inflammation is the local physiologic reaction of the body to noxious stimuli or irritants. Any irritant, whether of traumatic, chemical, or bacterial origin, produces a sequence of basic physiologic and morphologic reactions in vascular, lymphatic, and connective tissues. Host resistance factors and intensity, duration, and virulence of the irritant modify the ultimate character, extent, and severity of the tissue changes and, to some degree, the clinical manifestations. Inflammation brings to the area phagocytic cells to digest bacteria or cellular debris, antibodies to recognize, attack, and destroy foreign matter, edema or fluid to dilute and neutralize the irritant, and fibrin to limit the spread of inflammation. The injurious agent may cause reversible or irreversible changes to the tissues. Irreversible damage leads to tissue necrosis, whereas reversible damage leads to repair. Repair, or the return of the tissue to normal structure and function, begins as the tissue becomes involved in the inflammatory process. Removal of the irritant, exudate, and cellular debris and return of the vascular bed to normal enhance the reparative process. Fibroblasts from adjacent connective tissue and capillary buds from adjacent blood vessels proliferate in the area. The result is the production of new collagen fibers, matrix, and a rich supply of blood vessels to the area of injury. This reparative tissue, which contains new blood vessels, fibroblasts, collagen fibers, and inflammatory cells, is called granulation tissue. The inflammatory process resolves when repair has been completed. Clinical note: the objective of inflammation is to remove or destroy the irritant and repair damage to the tissue. Repair of the tissues depends on the severity of injury and host resistance. Symptoms. Inflammation produces the following symptoms: pain, from the action of cytotoxic agents released from humoral, cellular, and microbial elements on the nerve endings; swelling, produced by filtration of macromolecules and fluids into the affected tissues; redness; heat, produced by vasodilatation of the vessels and the rushing of blood to the affected tissues; disturbance of function, resulting from changes in the affected tissues in an inflamed pulp too, as in any other inflamed organ of the body. These symptoms occur, but only pain and disturbance of function are recognized clinically because of the encasement of the pulp by unyielding tissues. In acute inflammation involving the periapical tissues, all symptoms of inflammation may be recognized clinically. In the dental pulp and peri-radicular tissues, inflammation may be either symptomatic or asymptomatic. These two stages can be recognized only at the histologic level and depend on the preponderant type of cells in the lesion. The main cell of a symptomatic acute inflammatory lesion is the polymorphonuclear neutrophil. In asymptomatic chronic inflammation, lymphocytes, plasma cells, monocytes, and macrophages are predominant. Grossman binder. In 44 October 11, 2020, 12:49 and 58 seconds. Chapter 3 Rationale of Endodontic Treatment 45. As a rule, no definite demarcation exists between acute and chronic inflammation. Lesions usually have both types of cells, with either acute or chronic cells predominating. Cellular mediators of inflammation. Inflammation and its sequelae are mediated by specific kinds of cells, and the following section presents a brief understanding of the role of each of these cells. Polymorphonuclear neutrophils. The polymorphonuclear neutrophils morphologically consist of a nucleus with 3 or more connected lobules and cytoplasm containing lysosomal and specific granules. They are present during the acute or early stages of inflammation, and although their main function is to phagocytize bacteria, they may also phagocytize and lyse fibrin and cellular debris. They are attracted to the area of inflammation by chemotactic factors produced by bacteria or by complement. Serum factors of complement and immunoglobulins called opsonins bind bacteria to the surfaces of the polymorphonuclear neutrophils. In the binding sites, the bacteria are encapsulated in vacuoles that move into the cytoplasm of the polymorphonuclear neutrophils and come in contact with the lysosomal granules. These lysosomal granules degranulate and release lysosomal enzymes inside the vacuoles for lysis of the bacteria. The polymorphonuclear neutrophils have a narrow range of life. They are destroyed in the inflammatory site when the tissue fluids fall to a pH of 6.5. This tissue change is due to the increased production of lactic acid during phagocytosis and the release of this product into the tissues during the death of the polymorphonuclear neutrophils. Destruction of the polymorphonuclear neutrophils also causes the release of the proteolytic enzymes pepsin and cathepsin, with resulting tissue lysis. The polymorphonuclear neutrophils, with the products of cellular lysis and debris, are the principal constituents of pus. Clinical note: polymorphonuclear neutrophils are the first cells to migrate from the vessels to the site of inflammation. Macrophages. Macrophages are derived from circulating monocytes. Immature monocytes in extravascular areas, such as areas of inflammation, differentiate into macrophages. Macrophages are phagocytic cells that ingest cellular debris, microorganisms, and particulate matter. They secrete certain mediators of inflammation, such as lysosomal enzymes, complement proteins, and prostaglandins. Macrophages enhance the immunologic reaction by ingesting, processing, and degrading antigen before it is presented to the lymphocytes. Their capacity to remove debris from the area facilitates repair. Macrophages are mononucleated cells that, in periods of great activity, may fuse with other macrophages to produce a multinucleated giant cell. Lymphocytes. Small lymphocytes appear in the chronic stage of the inflammatory reaction. These lymphocytes are intimately related to the immunologic system of the organism. Small lymphocytes have a large, spherical, or slightly indented nucleus surrounded by a thin band of cytoplasm containing small granules. Two types of small lymphocytes, B cells and T cells, are known. Both are derived from the pluripotential hematopoietic stem cells. Stem cells are carried by the blood to the thymus, where they become immunologically competent T cells. B cells, in contrast, are believed to become immunocompetent in the bone marrow, Fig 3.1. T cells have a long lifespan and are the most common cells of the lymphocytic series in the blood. They are responsible for cell-mediated immunity and for the immunosurveillance of the human organism. They recirculate through the lymphoid tissues and organs of the body, except the thymus, and are found in the paracortical areas of the lymph nodes. When T cells are stimulated by an antigen, a foreign substance, they develop into sensitized T lymphocytes. These T lymphocytes have various immunologic manifestations as follows: memory T cells, which speed the immunologic reaction in subsequent encounters with the same antigen. Helper or suppressor T cells, which stimulate or suppress the development of effector T or B cells. Effector T cells, which may produce cell-mediated immune reactions, such as delayed hypersensitivity. The sensitized T lymphocytes also release chemical mediators called lymphokines. Lymphokines may activate macrophages, polymorphonuclear leukocytes, and non-sensitized T cells, or they may produce interferon, which inhibits viral replication as needed by the immune response. B cells have a shorter lifespan than T cells. They are found in the blood in lesser numbers than T cells and in the cortical areas of the lymph nodes. When activated by an antigen, B cells become larger cells, called plasmablasts, which divide to form plasma cells and memory B cells. The memory B cells speed the immunologic reaction in subsequent encounters with the same antigen. The B cells are responsible for the humoral immunity of the human organism. The plasma cells are large, oval, or round cells with eccentric nuclei containing chromatin arranged in cartwheel form. The plasma cells produce immunoglobulins. Immunoglobulins are called antibodies when the antigen that triggers their production is known. Grossman binder.int 45 October 11, 2020, 12:49 and 58 seconds. 46 Grossman's endodontic practice. The immunoglobulins, of which the 5 major classes are IgM, IgG, IgA, IgD, and IgE, are involved in different defense reactions. These reactions include the following: neutralization of bacterial toxins by antitoxins, coating of bacteria by antibodies, or opsonization, to facilitate phagocytosis, lysis of bacteria by complement activation, agglutination of bacteria, combining of the antibody with viruses to prevent their entry into the cells, eosinophils, basophils, and mast cells. Other cells found in the pulp and peri-radicular tissue during the inflammatory response are eosinophilic leukocytes, basophilic leukocytes, and mast cells. The eosinophils are found in allergic and parasitic reactions. During the immune response, they are involved in phagocytosis of the antigen, antibody complexes, and detoxification of histamine. Basophils and mast cells are considered similar cells. Basophils are found in the hematopoietic system and mast cells are found in tissue. Both of them contain granules that, when stimulated by tissue injury or antigen, degranulate and release chemical mediators, such as histamine, a vasodilator, and heparin, an anticoagulant which can initiate an inflammatory or allergic response. Cytokines. Cytokines are low molecular weight proteins that stimulate or inhibit the proliferation, differentiation, or function of immune cells. They play an important role in modulating the inflammatory response of the immune system. Pro-inflammatory cytokines, example TNF-alpha, IL-1, and IL-6. Anti-inflammatory cytokines, example IL-4, IL-5, IL-10, and IL-13. Vascular changes during inflammation. Injury, regardless of the cause or intensity, causes 2 fundamental vascular changes: vasodilatation, increased capillary permeability, which, in turn, leads to a series of interrelated physiologic and morphologic changes characteristic of the inflammatory response. A brief vasoconstriction is followed by vasodilatation of the arterioles caused by the relaxation of the arteriolar and capillary sphincters. This process is followed by the opening of dormant capillary beds, which increases the blood supply to the affected area. Proteolytic enzymes released from injured cells, bacterial toxins, and traumatic mechanical forces are some of the injurious agents that may release histamine from mast cells to start the vasodilatation of the vessels. This vasodilatation is accompanied by an increased rate of blood flow through the vessels, a reduction in vascular reactivity, and a decrease in flow resistance. These changes increase intravenous pressure, blood flow, and permeability of capillaries. Histamine enhances the permeability reaction by contracting the endothelial cells of the venules and producing intracellular gaps. This process favors the filtration of plasma and macromolecules from the venules. The blood plasma escaping through the vessel walls is usually less viscous and lymphocytes B, TT, BB, BB, thymus, stem cells, hemopoietic tissues. Chapter 3 Rationale of Endodontic Treatment 47 contains less protein than blood plasma remaining in the blood vessels. In inflammation, the blood plasma that leaks into the tissues contains plasma proteins such as albumins, fibrinogen, and immunoglobulins and is called inflammatory exudate. Blood plasma containing macromolecules brings the chemical mediators and cells of inflammation into the inflammatory site to start the inflammatory reaction. This plasma also dilutes bacterial toxins, thereby reducing the potential of tissue damage, and helps to form fibrin to contain the inflammatory reaction. Hagemann factor or factor 12 of the blood clotting system is released into the tissues in the inflammatory exudate. This factor is activated by collagen, by damaged basement membrane of blood vessels, or by an antigen, antibody complex, and reacts with prekallikrein of the plasma or tissues to produce kinanes. The kinanes, such as bradykinin, produce dilatation and permeability of blood vessels. The Hagemann factor also activates the fibrinolytic and blood coagulating systems. Fibrinogen in the inflammatory exudate is acted on by the Hagemann factor to produce fibrin, which confines the inflammatory reaction to a limited area. Plasminogen from the plasma found in the inflammatory exudate is activated to plasmin. Plasmin may activate the complement system. Moreover, it digests fibrin and thereby aids in the removal of blood clots or fibrin plugs, or it may activate the kinase system. The inactive serum proteins of complement are also released from the blood in the inflammatory exudate. Immunoglobulins activate the complement cascade and produce anaphylatoxin, which acts on mast cells and causes the release of histamine. Complement activation also results in the release of a chemotactic factor, which aids in leukocytosis and lysis of bacteria. The fluid leaked from the vessels into the tissues accumulates, producing edema. The subsequent increase in tissue pressure causes the venules to collapse and reduces both the venous drainage from the area and the blood flow. The stasis of blood in the venules due to increased viscosity of blood from loss of fluid and the increased pressure resistance of the venules cause the leukocytes to migrate from the center of the blood vessels to the periphery. This process is called margination of leukocytes. After margination, the leukocytes adhere to the vessel walls. This adherence is termed pavementation of leukocytes. The next step in the inflammatory reaction is the emigration of the leukocytes. The leukocytes are attracted by complement to the site of inflammation and migrate through the vessel walls by amoeboid movement. This migration process is called chemotaxis. The polymorphonuclear neutrophils migrate first, followed by the monocytes and lymphocytes. Complement, prostaglandins, kallikrein, and bacterial products all may produce chemotaxis. The presence of complement, kallikrein, and bacterial products in the inflammatory site has been previously discussed. Prostaglandins, mediators of inflammation, produce vasodilatation, vascular permeability, and pain. They are derived from the cell membrane phospholipids. Phospholipase, a lysosomal enzyme produced by polymorphonuclear leukocytes, reacts with the cell membrane phospholipids to produce arachidonic acid, which, in turn, produces prostaglandins, thromboxanes, and leukotrienes. The polymorphonuclear neutrophils also produce lysosomal enzymes which give rise to chemotactic substances that attract more leukocytes to the area of inflammation. The vascular response continues with the aggregation of red blood cells in the vessels. This aggregation increases the resistance of the blood to flow. This resistance, along with the increase in blood viscosity produced by the loss of plasma, causes metabolic changes, such as a decrease in the oxygen concentration, an increase in carbon dioxide levels, and a lower pH in the inflammatory site. These changes are detrimental to the metabolism of the pulpal tissue, as elsewhere in the body, because they prevent the removal of waste products. Box 3.1 illustrates the sequelae of pulpal inflammation. Box 3.2 depicts the protective mechanisms involved in limiting the pressure increase within the affected pulpal area. Protective mechanisms in limiting the pressure increase within the affected pulp. The locally increased pressure in the inflamed area will favor net absorption of interstitial fluid from adjacent capillaries in inflamed tissues. Increased interstitial fluid pressure increases lymphatic drainage. Increased interstitial fluid pressure will lower the transcapillary hydrostatic pressure difference and oppose further filtration. Discontinuity in the endothelium and fenestration of pulpal capillaries may facilitate exchange mechanisms. Proper functioning of the feedback mechanisms will limit the increased tissue fluid pressure to the affected area, corresponding to that shown histopathologically. Box 3.2. Sequelae of pulpal inflammation. Physical, chemical, or biological irritation to the pulp. Inflammatory changes. Protective mechanisms, refer to box 3.2. Removal of the irritant and/or therapeutic measures persistence of irritating factors. Healing, leading to normal pulp vicious cycle of inflammation, refer to box 3.3. Box 3.1. Grossman binder. In 47 October 11, 2020, 12:49 and 58 seconds. 48 Grossman's endodontic practice. The vicious cycle of inflammation may lead to total necrosis of the pulp. This phenomenon is illustrated in box 3.3. The migration of monocytes and lymphocytes renders the inflammatory site capable of an immunologic reaction. As the inflammatory reaction progresses, the following cells are found in the inflammatory site: 1. Macrophages that are necessary to process the antigen. 2. Plasma cells that are derived from B lymphocytes and synthesizers of immunoglobulin. 3. Lymphocyte mediators of the immune response. Extravascular immunoglobulins found in inflamed pulp tissues, as well as those in plasma cells, are predominantly IgG, although IgA-, IgE-, and IgM-containing plasma cells are present. The presence of these immunoglobulins indicates that the pulp possesses the mechanism for immunologic reactions, which in themselves contribute to pulpal and peri-radicular disorders. The recovery of the pulp may be explained by some unique vascular responses. Arteriovenous anastomosis and U-turn. Loops open in the pulpal vasculature to reduce the flow to the area of inflammation and thereby decrease the vascular pressure. The increased tissue pressure plays a role in the recovery of the pulp by allowing return of macromolecules and fluids to the venules. These two changes return vascular pressure and tissue pressure to normal and stimulate the repair process. Peri-Radicular manifestations. If the inflammatory response overwhelms the pulp, with resulting partial or total necrosis, the root canal will serve as a pathway to the peri-radicular area for the noxious products of tissue necrosis and antigenic agents. The inflammatory and immunologic responses in the peri-radicular area occur as in the pulp. On reaching the peri-radicular area, these noxious products cause bone resorption and initiate the formation of granulation tissue in place of normal peri-radicular tissues. The peri-radicular pathologic tissues contain polymorphonuclear neutrophils, lymphocytes, plasma cells, macrophages, and mast cells, along with immunoglobulins IgG, IgA, IgM, and IgE, and complement. In the presence of inflammatory cells, immunoglobulins, and complement in the peri-radicular tissues, anaphylactic, cytotoxic, antigen, antibody complex, and delayed hypersensitivity reactions may occur. Reports indicate that some endodontic flare UPS are mediated by IgE reactions and that bone resorption is mediated by a lymphokine called osteoclast activating factor. These findings point to the important role that immunologic reactions play in the physiology and pathology of the peri-radicular tissues. Tissue changes following inflammation. Tissue changes following inflammation are either degenerative or proliferative. Degenerative changes. Degenerative changes in the pulp may be one of the following: fibrous resorptive calcific. If the degeneration continues, necrosis will result, especially if thrombosis of the blood vessels occurs, or if leukotoxin is released as a result of damage to the tissue cells. Another form of degeneration is suppuration. When the polymorphonuclear cells are injured, they release proteolytic enzymes, with resulting liquefaction of the dead tissue. This process is suppuration or formation of pus. 3 requisites are necessary for suppuration: 1. Necrosis of tissue cells. 2. A sufficient number of polymorphonuclear leukocytes. 3. Digestion of the dead material by proteolytic enzymes. If the reaction is not great enough, because the irritant is weak, an exudation consisting chiefly of serum, lymph, and fibrin, serous exudate, will result. All dead cells, particularly polymorphonuclear cells, liberate proteolytic enzymes. In this way, an abscess is formed. Because the enzymes digest not only the leukocytes but also the adjacent dead tissue, microorganisms are not necessary for the development of an abscess. For example, a sterile abscess may result from chemical or physical irritation in the absence of microorganisms. Mechanism of vicious cycle of pulpal inflammation, Kim S. 1985 and Van Hassel H.J. 1971. Irritation, dental caries, trauma, or operative procedures. Localized inflammation, vasodilatation, increased local tissue pressure. Localized necrosis, venous collapse, reduced blood flow, waste product accumulation. Progression of inflammation, wider zone of inflammation, spread of vascular disturbance. Generalized necrosis, necrosis of additional tissue, release of lysosomal enzymes, extensive collagen destruction. Irreversible pulpitis. Box 3.3. Grossman binder. In 48 October 11, 2020, 12:49 and 58 seconds. Chapter 3, Rationale of Endodontic Treatment. 49. Proliferative changes. Proliferative changes are produced by irritants mild enough to act as stimulants. Within the same area, a substance may be both an irritant and a stimulant, such as calcium hydroxide and its effect on the adjacent tissue. In the center of the inflammatory area, the irritant may be strong enough to produce degeneration or destruction, whereas at the periphery, the irritant may be mild enough to stimulate proliferation. Generally, if the tissue is in apposition, as in the case of an incision for root resection, fibroblastic repair will take place. When a gap is present between the tissue parts, repair is made with granulation tissue. Granulation tissue is resistant to infection. The principal cells of repair are the fibroblasts, which lay down cellular fibrous tissue. In some cases, collagen fibers may be substituted, dense cellular tissue is then formed. In either case, fibrous repair is the result. Destroyed bone is not always replaced by new bone, but it may be replaced by fibrous tissue. Endodontic implications. The reaction of the peri-radicular tissues to noxious products of tissue necrosis, bacterial products, and antigenic agents from the root canal has been described by Fish. He established experimental foci of infection in the jaws of guinea pigs by drilling openings in the bone and packing in wool fibers saturated with a broth culture of microorganisms. 4 well-defined zones of reaction were found: I zone of infection 2. Zone of contamination 3. Zone of irritation 4. Zone of stimulation. I zone of infection. This zone is characterized by polymorphonuclear leukocytes. In Fish's study, infection was present in the center of the lesion, and microorganisms were found only in that area. The only microorganisms not disposed of by polymorphonuclear leukocytes were found in Haversian canals or in fissures in the bone matrix made by the burr. 2. Zone of contamination. This zone is characterized by round cell infiltration. Around the central zone, Fish observed cellular destruction, not from bacteria themselves, but from toxins discharged from the central zone. It was not established whether the toxins were tissue breakdown products or exotoxins. In this area, bone cells had died and had undergone autolysis, so the lacunae appeared empty. Lymphocytes were prevalent everywhere. 3. Zone of irritation. This zone is characterized by macrophages and osteoclasts. Fish found evidence of irritation further from the central lesion as the toxins became more diluted. In this area, also distinguished by small, round cells, normal bone cells and osteoclasts could just about survive. The collagen framework was digested by phagocytic cells, the macrophages, while osteoclasts attacked the bone tissue. In this area, the histologic picture is the one that signifies a body's attempt to initiate repair. 4. Zone of stimulation. This zone is characterized by fibroblasts and osteoblasts. At the periphery, Fish noted that the toxin was mild enough to be a stimulant. In response to the stimulation, collagen fibers were laid down by the fibroblasts, which acted both as a wall of defense around the zone of irritation and as a scaffolding on which the osteoblasts built new bone. This new bone was built in irregular fashion. The root canal is the site of infection. The microorganisms in the root canal are rarely motile and do not move from the root canal to the peri-radicular tissues. However, they can multiply sufficiently to grow out of the root canal, Fig 3.2, or the metabolic products of these microorganisms or the toxic products of tissue necrosis may be diffused to the peri-radicular tissues. As the microorganisms gain access to the peri-radicular area, they are destroyed by the polymorphonuclear leukocytes. When the microorganisms are sufficiently virulent, or when enough are present, they overwhelm the defensive mechanism, and a peri-radicular lesion results. When they are of low virulence and numbers, however, a stalemate occurs. The polymorphonuclear leukocytes destroy the microorganisms as rapidly as they gain access to the peri-radicular tissues. The result is a chronic abscess. The toxic products of the microorganisms and the necrotic pulp in the root canal are irritating and destructive to the peri-radicular tissue and, together with the proteolytic enzymes released by the dead polymorphonuclear leukocytes, help to produce pus. By analogy, we can apply the knowledge gained in Fish's experiment to understand better the reaction of the peri-radicular tissues to a pulpless tooth, Fig 3.3. At the periphery of the destroyed area of osseous tissue, toxic bacterial products may be diluted enough to act as a stimulant. The toxic products from the root canal diffuse from the apical foramen and destroy bone in the immediate vicinity of the root apex. Further away, the toxins are so diluted that they act as a stimulant and form a granuloma. Fibroblasts then build fibrous tissue, and osteoblasts delimit the area with a wall of sclerotic bone. If, in addition, the epithelial rests of Malaceae are stimulated, a cyst will form. Microorganisms are usually transient in peri-radicular tissue, even when an area of rarefaction is present radiographically. These transient invaders are destroyed by the polymorphonuclear leukocytes in the manner already described. Although this phenomenon explains the development of Grossman binder. In 49 October 11, 2020, 12:49 and 58 seconds. 50 Grossman's endodontic practice. Figure 3.2, A. SEM view of the apical surface of mesiobuccal root of maxillary first molar. Each alphabet is denoting portal of exit of the root canal. B. SEM view under higher magnification of one of the portals of exit, B, of the root canal, Fig 3.2a, showing colonies of coccus bacteria. C. SEM view under higher magnification of Fig 3.2, B, showing colonies of coccus bacteria. Courtesy, Volodymyr Kovtun, Ukraine. A. B. C. Radiolucent areas as a result of infection of the pulp. It does not altogether explain the development of such areas following trauma. The pulp may be sterile, but a radiolucent area develops nevertheless because of tissue breakdown products of the pulp that irritate the peri-radicular tissues. Clinical note: when the root canal has been treated, the reservoir of bacteria or noxious products gets eliminated. When the root canal is cleaned and obturated, the destroyed peri-radicular bone will undergo repair. Grossman Binder. In 50 October 11, 2020, 12:50. Chapter 3 Rationale of Endodontic Treatment 51. Zone of Stimulation. Zone of Irritation. Zone of Contamination. Zone of Infection. Figure 3.3 Schematic diagram showing bacteria in the root canal and the zones of infection, contamination, irritation, and stimulation.